All you.
Hi everyone, I'm Stephanie. I'm a recent PhD from Washington State University. I work in Eric Lofgren's lab, and today I'm going to be talking about what was part of my dissertation titled Modeling ICU's MRSA Acquisitions with Different Staffing Levels and Direct Care Task Models. So, a little bit about big picture before we dive into things. Most people know infectious diseases spread in different ways in different areas, in part due to context-dependent contact rates. And so, to kind of understand that, we need to better understand human behavioral components and how people's changed behaviors affect disease spread. This can usually be in response to policy changes, but then there's also institution culture, such as, what does the institution think about contact rates or your risk as an employee or somebody or a customer? And there are many different methods to study contact rates. It really depends on the question that you want answered. So we're going to just talk about one of them today, which is modeling. But just a little background for people who don't know contact rates. So for directly transmitted diseases, contact patterns drive the spread of infectious pathogens in both space and time. And a contact rate is seen as the number of close contacts per infected individual. And contact rates are very context specific. There's really not one size fits all. So seen here, these two graphs show individual contact data from 40,000 UK people during the COVID pandemic. And A here shows the distribution of contacts for those younger than 18 or those older than 18. And we see that those that were under 18 had a lot less contacts than people who were over 18. So you see like this goes between 10 to 100, and this one kind of goes centers around 100 contacts. But then graph B over here shows the example of the daily social contact patterns for four randomly selected individuals from the 40,000. And you can see that with this contact structure, there are changes due to the person and where they might go. So like these two didn't have a lot of people, but then these two people had a lot of people, and you see a lot of them tend to be like work or school contacts that they have contact with. So individuals and communities both do things that drive contact and lead to risk of infections. Individuals, their beliefs and perceptions, their behavior, their job or occupation can increase or decrease their chance of contact. And then also communities, what's their environmental? Is this good walking? Is this, is there lots of trees that people want to go outside or not? Is there transportation that, they might be forced to be in crowded buses and there's lots of contact there, or what's their housing situation? So all of this can decrease or increase their contact risk. And I'm particularly interested in individual contact risk by occupation and its community impact. So, as I talked about, we're going to go kind of more into hospitals. So, with contact rates in hospitals, we really do have a good understanding of who does what from the literature. There's been a lot of different types of observational studies that we can kind of say, okay, we know that nurses kind of touch patients this amount of time, or doctors do this, or this is where they go. Respiratory therapists do this, but then there are areas of research that we can still look at to help inform healthcare associated infections or HAI models. We can look at staffing levels, we can look at hospital design or ward design. Um, so we're just trying to understand a little bit about, how we can affect contact rates with how other areas of research. And so this is a graph from Otter et al. Looking at, hospitals have a lot of places where infectious diseases can spread either from patient to patient, from here, like direct patient contact, or using a healthcare worker as an intermediary, as seen here. And my model that we're going to be talking about coming up, I looked specifically at healthcare workers as they, one, tend to go more places, see more patients, and pick things up from the environment as well as patients themselves. And again, this is really the pathway I'll be focusing on for the rest of my talk. Um, so I'm talking about a paper that's up for preprint at medRxiv, which will soon be admitted to the American Journal of Infection Control, which is called Healthcare Worker Staffing Ratios Affect Methicillin-Resistant Staphylococcus aureus Acquisition. Going forward, that will be called MRSA. It's just a mouthful. So a little bit about hospital models. A common HAI model is the modified Ross McDonald model here. It was originally derived from a malaria model, but does well with healthcare settings. And it's used when you're trying to model diseases that tend to be spread by healthcare worker hands, such as MRSA or C. diff or VRE. So what happens is basically uncolonized patients can become colonized with contact with a contaminated healthcare worker and vice versa. An uncolonized staff member can become contaminated by contact with a colonized patient. We see here that healthcare workers are only transiently contaminated, but patients are considered colonized for the rest of their stay, similar to how vectors that were once infected, how vectors once they get infected stay infected. So I had a former lab mate, Matt Meechin, who looked at three different ways of modeling the Ross McDonald graph. This is A, which was one way, and then he separated the staff into the doctors and then the nurses, and then he did a metapopulation cohort model where each nurse was assigned to certain patients at most of the time. And we saw that that was the best or most realistic to real data of the three. So we're like, great, this is really interesting. But then we were wondering, what if the staffing level had to change? And what assumptions do we make when we model staffing levels? And then we also wanted to understand what happens in two different scenarios. One, this infinite scenario, so no matter what the contact rate, the number of tasks stay the same. And then this finite scenario where contact rates and tasks alter due to the number of staff. So this is our baseline model. So we had a 3-to-1, 3 patients to 1 nurse patient baseline model. And then we had one doctor seeing all 18 patients. So that was our standard baseline that we have all the direct observation information for. So we use that as our model. But then we had 5 different nurse staffing models as shown above. We went, from that 3-to-1 up to a 1-to-1, so 18 nurses in the unit, down to a 9-to-1, so 2 nurses in the unit. And then on top of that, we added 1 or 2 more doctors to a total of 3 that saw all 18 patients randomly with no further metapopulations for them. And so even with all the different ratios, each nurse had their assigned patient cohort and were with them 85% of the time. The rest of the time, the other 15% was helping patients outside their cohort because another nurse was on a break, a patient needed care that needed another hand, there was a code. But also within and outside of their cohort, a nurse saw a patient randomly. And we ran all these models for 2 different task models, the infinite and then the finite scenario models. So a little bit more about our models. Healthcare workers were either only uncontaminated, so DU or an NU, or contaminated DC or NC. And patients were either uncolonized or colonized, so a PU or a PC. And again, that was that Ross McDonald. So they can only contaminate each other. They can't contaminate, like a doctor cannot contaminate a doctor or a nurse. They can only do that with the patients and vice versa. Again, we're looking at the infinite task model, which is infinitely many tasks to perform within an ICU within a given shift. So a new staff affects the number of tasks performed, but the per staff contact rate between everyone remains constant. Versus the finite task model, there's a large but fixed number of tasks to be accomplished in a shift. And so adding a new staff member alters the per staff contact rate, but keeps the overall rate fixed. And then each scenario at the end was stochastically simulated 1,000 times to obtain a distribution of the number of MRSA acquisitions in a year. And we are displaying these going forward as MRSA acquisitions per 1,000 person years. So I know I've been talking about the infinite and the finite task models. So I just wanted to kind of talk because it's sometimes easier to visualize. So for the infinite task model, think that you have 2 nurses. That means that there's 20 tasks, there's 10 each. So if you add a nurse, everyone still does 10 tasks. So now there's 30 tasks being done an hour. But if you take away a nurse, then there's only 10, that's 10 tasks being taken away. So if there's 1 nurse, there's only 10 tasks being done. Versus if you have a finite task model, which we're looking at, we have a set number of tasks, let's say 20, just using 20 for ease. So again, if we have 2 nurses, each nurse is doing 10 tasks, but if we have 4 nurses, each nurse is only doing 5 tasks. Um, so we think that hospitals are most likely a bit mix of both task models. It kind of depends on the type of hospital. What ward is this? ICU might be different than oncology versus a step down. It could also determine the time of year. Is this kind of a slow season, or is this more like respiratory ILIs? Like, are everybody running around? And as modelers, we tend to do extremes so we can show both the worst and the best of these models. So these are the parameters that we used. We can see here that nurses had on average, about 3.97 direct care tasks per hour. Physicians have about 0.18. So this is our this is our contact rates that we were using. But with that, um, that also affects iota and tau over here. Um, and remember, these are our infinite parameters here. So no matter the number of doctors or nurses, the rho, iota, and tau all stay the same. But it does change for our finite parameters. So here we see the infinite models and the number of, so down here is the number of patients per nurse with 1 doctor, per 2, per 3, and then this is the MRSA acquisitions per person year. And we see here that the baseline model had a median of about 8.2 acquisitions per 1,000 person years. And then when looking at the rest, you can see that models go up slowly the more patients a nurse has. They go slow. It is significant, but it is slow. And you see that doctors don't have a large effect. Adding a second doctor versus a third doctor, they look very similar. So we saw that going from like a 3-to-1 to 2-to-1 ratio had a 21% decrease of MRSA acquisitions. So you had 6.5 acquisitions per 1,000 person years. If you went up to a 6-to-1, you increased acquisitions by 27%. But we saw adding a second doctor and third doctor both decreased MRSA acquisitions by 11%. We didn't really see a difference. There was no difference between the second or a third doctor. And so when you compare this infinite model to your finite models, you see much more of an exponential growth. You see the y-axis now goes up to 80 MRSA acquisitions, where with the infinite it was 20. We see going back to that 2-to-1 ratio, you decrease acquisitions now by 48%. And then for a 1-to-1, you actually decrease it by 83%. And if you do the 6-to-1 ratio, you increase acquisitions by 348%, going from like eight acquisitions to like 29 acquisitions. And if you go up to 9, it's about 779%, so 64 MRSA acquisitions per 1,000 person years. And again, similar to the infinite models, we see that doctors had similar lack of impact by adding a second or adding a third. So we really see that it is the nurses driving this. So in conclusion, all else being equal, ICU staffing levels have a potentially dramatic increase on MRSA acquisition rates, and staffing should be considered a component of infection prevention, and reduced levels of HAI should be factored in when considering staff budgeting. We also saw that nurses, not physicians, are the drivers of acquisitions. As we saw, no difference seen between 2 and 3 physicians in either of the different task models, and physicians had less than 15% impact on any model. So if you need to get HAIs down, add more nurses. We also saw that conceptualization of a workload had a more dramatic impact than any given staffing level. So think about how workload and the ensuing contact rates is the better idea. So if you really are trying to model or you're trying to think about this, really think about what the ICU looks like, to think about if you need to act on this. Like if you're expecting an ICU to be like the finite model, but it's actually the infinite model, it's going to be you have to be realistic about what that looks like. Because as I said, both finite and infinite models are realistic. You just have to understand which one fits the hospital or ward of interest. So for other modelers, Please state your workload and contact assumptions in your hospital model, but also any other models. This could be anything for, classrooms or anything else. This is something that should be considered if you're looking at staffing levels at any level. So thanks, and I'm happy to take any questions.